Our next lecture is actually a short one. It's looking at the adrenal hormones. So, for a lot of the endocrine system, if you remember, we have to deal with the hypophyseal pituitary axis. And so, the pituitary gland is going to be controlled by the hypothalamus. And if you remember, there's multiple different endocrine organs that we can put down here that the tropic proteins released from the anterior pituitary are going to help to control. In this chapter and lecture, we're going to look at the ones released by the adrenal gland. And so, as we look at this axis, all along it, we can intervene and affect the secretion of these hormones. And so, if we start at the hypothalamus, you can see if the body is under stress, the hypothalamus releases corticotropin releasing factor. And so, along with that, it can also secrete something called cosentropin. Those are going to travel right to the anterior pituitary, and the anterior pituitary releases its hormone called corticotropin, or ACTH for short, that can travel then to the adrenal gland. And in the adrenal gland, if you remember, there's two areas to the adrenal gland: the adrenal cortex, which is going to release the hormones of interest for this lecture, which are the glucocorticoids, mineralocorticoids, and gonadoccorticoids. Those are then going to be released. Glucocorticoids have many targets in the body. Mineralocorticoids help us to control our fluid homeostasis in the body, and the gonadoccorticoids are, of course, going to go to the reproductive system and have influence there. There's also the adrenal medulla, the middle, and that releases catecholamines in response to the sympathetic nervous system. Once the adrenal gland releases these hormones, there's going to be a negative feedback mechanism that's going to go to the anterior pituitary and the hypothalamus and have them be inhibited, and they're not going to release any more of their stimulating hormones until the levels of the hormones released from the adrenal cortex are decreased. And so the hormones that are released, we can actually use them for replacement therapy. And the hormones here are released from the adrenal gland. We prescribe them for anti-inflammatory diseases, for treatments of allergic reactions, and even some cancers. The hormones that are released here from the hypothalamus are corticotropin and are cosinotropin. We actually can use those for diagnostic testing. So if somebody, we need to test whether or not their adrenal gland is functioning properly, we can give these hormones and then measure to see whether or not we're having release of hormone from the adrenal gland. So all along the pathway, the hormones are very important, and we can use them in diagnostics or treatment for our patients. So if we look at the mineralocorticoids here first, the most important one is aldosterone, and it's regulated via the RAS system. Remember, renin, angiotensin, aldosterone system. When aldosterone is released, it causes sodium retention and potassium secretion. And we do have our drugs that we've already talked about, actually, that can influence RAS. Instead, here we're going to focus on our glucocorticoids. So glucocorticoids, if you look at their structure, if you can see their structure here, it's going to be lipid soluble. So it can come right into cells, and as it does, it's going to bind an intracellular receptor. And if you remember, your intracellular receptors that bind hormones generally have an effect on gene transcription. And that's how the glucocorticoids work. So its activated receptor is going to travel into the nucleus, as we can see here, And it's going to bind to responsive elements and promoter elements in a variety of different genes. And once it binds, it can stimulate or inhibit gene transcription. And so, in different types of cells, and as it binds to different genes, promoter regions, we're going to have different biological effects. And so, those effects can either be positive, why we would want to give a particular or a glucocorticoid to treat a particular disease, or it can be negative and give us some of our adverse effects. So, why do we have glucocorticoids? They have many functions. They have a big role in metabolism. They increase our blood glucose levels. They help with protein catabolism, breaking down proteins, and lipolysis, breaking down fats. If you think about when we release glucocorticoids naturally, we generally do it when the body's been under stress for a long time. And so, if you think about somebody who's been under stress for a long, long time, generally, we see people who they gain weight, they get sick easily, and they're overly tired. And if you think about it, they also are at higher risk for diabetes and hypertension. So part of that is because the glucocorticoids function in metabolism. We see hyperglycemia start to occur. It's because they can increase blood glucose cell levels. We're going to have catabolism happening, lipolysis, that might help to redistribute fat to different areas of the body. It is a stress hormone, so it's hoping by lipolysis and protein catabolism and increasing glucose levels to supply the body with the components to make extra ATP and energy to keep going. There's vasoconstriction. This is why people under stress for a very long time generally have high blood pressure as well. The glucocorticoids also can alter our blood cell levels. What we see is that they can redistribute or decrease our white blood cells. And they increase red blood cells, platelets, and some neutrophils. As well, they inhibit a step where we can make our inflammatory mediators and prostaglandins. So if you look, phospholipid from the plasma membrane gets converted into anaconic acid, and then we can use that and put it through different signaling pathways, and that's how our cells can release inflammatory mediators. And so the corticoid steroids actually inhibit one of these first steps here, and because of that, they have an anti-inflammatory effect. And that's one of the reasons glucocorticoids are prescribed, is to decrease inflammation in the body. So if we look, there are many great therapeutic effects to prescribing glucocorticoids. So if you look at how they affect immune cells and the associated tissues and organs, we get this nice anti-inflammatory effect. We can have immunosuppression, anti-allergy, and secondarily, because you're bringing down inflammation, there can be pain relief. As well, we can decrease blood vessel permeability, and hopefully that will help with edema or swelling. Now, if you also take a look at the bottom part of this circle and look at all the different organs and tissues, you can see there are some very significant side effects associated with glucocorticoid usage. So the hope is that patients don't have to be on these long to try to minimize side effects. But for some patients, especially those where we're using these for immunosuppression or anti-inflammatory, they do have to be on them for a while. And so a lot of these very significant side effects like hypertension and cataracts, neuropsychiatric disorders, hyperglycemia, weight gain, osteoporosis, and infections can be very, very serious for these patients. So glucocorticoids can affect like we just saw, many other organ systems, and they can also affect the glomerular filtration rate. We see then exacerbate ulcers in the GI tract. Many patients complain of changes in their mental status. It's common to have depression or altered sleep, um, bone loss, the osteoporosis, and myopathies are a very big issue. And lastly, we have Cushing syndrome. So, Cushing syndrome is a bunch of clinical features that we see that are very significant. And different people will have different combinations of these. But if you read through, I'm not going to go all the way through this list, but I would like you to pause the video and read through the clinical features of Cushing syndrome and what we see in these patients because it is significant. One of the ones that we see a lot, and it's worth Googling it because it's very stereotypical of Cushing syndrome, we see fat redistributed on the body. And so a lot of times people will have fat redistributed to their face, and their face will become very round. And sometimes you'll see that referred to as moon face, like a full moon. And they'll have fat gather at the base of their neck between the shoulder blades. And so they refer to that as a stereotypical, like, buffalo hump of Cushing syndrome. So the therapeutic uses, we've seen a couple of these now on our previous slide with the circle, but we do use these as a replacement therapy for adrenocortical insufficiency. So if there's a defect in our hypothalamus pituitary axis, if one of those organs is not secreting the proper hormones, or if there's a defect in the adrenal gland, which is called Addison disease, where the patient does not make enough glucocorticoids, then we can give them a replacement. And we can give hydrocortisone, which is identical to the natural cortisol that the body releases. We also use it as a replacement therapy for congenital adrenal hyperplasia. So this is where we have an enzyme defect that helps us to synthesize our adrenal steroids. So what this looks like, or how the characteristics of this play out, really depends on the sex of the individual and their age. And so we can have in women exaggerated masculine characteristics. And that's because the adrenal glands might overproduce androgens, so our testosterone and similar hormones. The symptoms then can be like excess facial and body hair, baldness, acne. We can have a deepening of the voice. There can be increased sex drive. The uterus in a woman might shrink. The clitoris might enlarge. Breasts can become smaller. Menstruation can stop. In female infants who might have the congenital adrenal hyperplasia, the genitals actually might start to resemble those of males. In children, growth can accelerate, and as it does, we might have the growth plates close prematurely, and so they might have a short stature then as the ultimate result. In boys, we see that they can experience premature sexual maturation as well. So how it's treated then, we can give the corticosteroids that the adrenal gland should be producing. And what that does is it works by a negative feedback mechanism. So it will go to the hypothalamus and it will go to the pituitary gland and have them decrease their secreted hormones so that hopefully then we decrease input to the adrenal gland and decrease the amount of hormone being released. Another time when our glucocorticoids are prescribed are for allergies. So we see people who have like bronchial asthma, allergic reactions. When we have somebody who's getting an organ treatment, an organ transplant, we can give them, and those, for instances, for transfusion reactions or a drug reaction, to decrease the immune system's response. We also give them to decrease inflammation. And so, a big population of patients who are on or who have autoimmune disorders, and there's many types of autoimmune disorders, but we can prescribe these drugs to decrease the functioning and decrease the what's the best way to say it? To decrease the activation of the immune system. So that's a positive in these patients who have an overactive immune system. But remember, when you inhibit the immune system, now they're at a greater risk for having an infection. We also can give them to mothers whose fetuses might be delivered prematurely. So issues for infants who are premature is that their lungs do not have sufficient surfactant to be able to open up those alveoli, have them not collapse. And so we can give mothers glucocorticoids prior to the delivery of their children to help to assist in the lung maturation process. So there are many, many adverse effects to having glucocorticoid treatment. And so if you look, some of them are very significant. They can affect the skeletal organs, so bones. We can see decreased growth in children, osteoporosis because they can affect calcium balance in the body. They can affect metabolism, so people have an increased in appetite, and also body fat can redistribute. They affect blood pressure, so we see an increase in hypertension in these patients, along with fluid retention. We see edema, we see glaucoma. Because we're decreasing the effectiveness of the immune system, like I said before, they're at a high risk for infection. They can have impaired wound healing. That goes right along with, we can exacerbate symptoms of peptic ulcers as well. Um, Patients also have neuropsychiatric disturbances as well. Some people have euphoria, some people can have depression, some people it disturbs sleep. So there are mental alterations with these drugs as well. Because these drugs work in a negative feedback loop with the pituitary gland and the hypothalamus, we have to be very, very vigilant about how a patient comes off them, and there can be withdrawal effects. So these drugs are suppressing our hypothalamus pituitary adrenal axis. And so if we just remove all of the drug all at once, the adrenal gland will not be able to kick in and release natural mineralocorticoids and glucocorticoids. It will take a while for the adrenal gland, for our hypothalamus pituitary gland to signal to the adrenal gland to start to make those hormones again. So if we remove everything all at once, we're not going to have the natural hormones there, and that can lead to what we call adrenal insufficiency. And one of the big issues with that is not having those mineralocorticoids that control our fluid and electrolyte balance in the body. So we can have patients who have sodium and blood volume depletion, and they're then going to experience orthostatic hypotension and tachycardia. And so to avoid this, because it can be lethal in some patients, to avoid it, the drug dose has to be tapered over a matter of days. We also have inhibitors of the adrenocorticoids. And so one of them, the first one here, are ketoconazole. that inhibits gonadal and adrenosteroid hormone synthesis. So we can use that drug to treat Cushing syndrome. Our second one here, the spironolactone, that's an antihypertensive drug. If you recognize it, it's a diuretic that also antagonizes aldosterone, and it also and testosterone synthesis. So we can use it to treat hyperaldosteronism and also the hirsutism in women who might be making too much too much of our androgens. And the last one here as well are eplerenone. That's an aldosterone antagonist. And so there again, it can be used to inhibit the RAS system. And if we antagonize aldosterone, then we would get rid of the effect of it reabsorbing sodium and getting rid of potassium. So those are the adrenocorticoids. You can see it's a very short list of things that it does, but they are very, very important, especially for anti-inflammatory purposes. It's a very important drug class.